thank you all for enjoying this afternoon. We have one more fantastic session. This one's focused on cardiovascular health. It's global strategies for cardiovascular health, enhancing action plans and partnerships. And this session is in partnership with World Heart Federation to discuss the urgent need for countries to develop and implement comprehensive cardiovascular disease action plans and ensure its successful implementation. It is my pleasure to welcome Alice Park to the stage and our esteemed panelists. Please.
Well, good afternoon, everyone, and thanks for sticking with us. Last session of the day. Promise you it'll be worth it. I am Alice Park. I'm Senior Health Correspondent at Time, and it's my pleasure to introduce our panelists today. On my right is Dr. Jenelle Krishnamoorthy from Merck & Company. She is Vice President and Head of Global Public Policy and Corporate Affairs. And to her right is Dr. Tom Gaziano, Associate Professor at the Harvard T.H. Chan School of Public Health and Science Committee Chair for the World Heart Federation. And to his right, the Honorable Dr. Budi Gunadi Sadikin, Minister of Health for the Republic of Indonesia. So welcome all of you. I'd like to start by providing some context for our discussion this afternoon. Heart disease has been the leading killer globally for more than 3 decades now, and it accounts for a third or 33% of deaths annually. 13% of global deaths are due to ischemic heart disease, or what we know better as heart attacks. And since 2000, ischemic heart disease has been the largest increasing cause of death worldwide. So I wanted to start with you, Dr. Gaziano. I thought we knew what the risk factors were, and we have good treatments for addressing those risk factors. Explain those statistics from your perspective.
Well, I think of Dickens' sort of comments. It's been the best of times and the worst of times where I think we are now. We have seen, as you mentioned, since the 1970s in the United States and most high-income countries, a continuous decline in cardiovascular disease, where nearly 800 per 100,000 Americans were dying every year, to now 300. So that's a significant progress. And we pushed the age when that happens to nearly a decade later in high-income countries. So that's been a great success. In high-income countries, and particularly in the United States, though, we've seen something that's been really, I think, concerning in that there's been a leveling off of that decline in the last 5 to 10 years. And for us to try to understand that, it ends up being a competing set of risk factors, improving blood pressure control, improving lipids, but we've seen an obesity epidemic and diabetes epidemic, and so it's a confluence of these different trends that have us where we are. And we look at low and middle-income countries, though they have not seen those kinds of initial positive trends that we've seen in high-income countries, but both of them are facing that. We have 1.3 billion people with hypertension in the world. 80% of them, or nearly 1 billion people, do not have it controlled. And so that is still a significant problem. In the United States, it's 50%. The best country, it's 55%. So the global average is 20. That means some countries are controlling it at 5%. And so while we think about these action plans, it does need to be on a country-by-country basis for us to be able to pursue that, because different countries are facing different challenges, different trends, different infrastructure, and workforce to be able to deal with it. And the World Heart Federation is starting this request for each country to have a national CVD action plan, World Heart Day 5 days from now, with the goal of creating or releasing a petition on that day to try to get 1 million signatures to say that we need this in each individual country, because different countries will have different needs and solutions to the problem.
And to Dr. Gaziano's point, Minister Sadikin, I wonder if you can tell us about the challenges that you face in Indonesia. According to the World Health Organization, heart diseases and heart disease-related issues rank as the 2 leading causes of death in your country. So tell us a little bit about what Dr. Gaziano was talking about in terms of the factors that are contributing to that.
Yeah, so first I would like to do some minor corrections. I'm not a medical doctor, you mentioned. I'm a nuclear physicist by training. 30 years as banker. I used to run the largest bank in the country, and suddenly out of the blue, the president assigned me to become Minister of Health, the first time Minister of Health in Indonesia without medical background during pandemic, before the peak of the pandemic. So now here I am, talking with all the famous doctors about heart disease. So by the way, for your information, Indonesia cause of death, number one is stroke, also cardiovascular, 300,000. Heart disease is 250,000. And the way the Indonesian record things, if you know the numbers, the formal numbers, the actual numbers may be twice or 3 times bigger than that, my experience during COVID. So I think close to 1 million deaths because of stroke and 1 million deaths because of heart disease. And then the issue that I have is, at that time I asked the professor, if heart disease or stroke happens, what should I do? Budi, in 4.5 hours, you have to send it to the hospital. You have to do ballooning the heart or put a ring inside your heart, or to do thrombectomy and coiling to your brain after to do CT scan. Okay, 4.5 hours, then I need to deploy, what devices that I need? A cath lab. So I need to deploy cath lab in 514 cities. Why are you doing it? Yeah, because if you get a heart attack and stroke in Los Angeles, you cannot bring it to San Francisco, right? Because it's too long. And then they realized, yes, actually it's worse than that. Indonesia has 34 provinces. Only 28 provinces have a cath lab. So that means if you have heart attack in California, you have to send the guy to Nevada or Oregon. That is what happened in Indonesia. And even in the cities, out of 514 cities, we only have 44. So that's why last year, I'm a banker, come to World Bank, sign a deal with the president of World Bank, $4 billion loan, December. And I'm deploying cath lab at 514 cities and also deploying open heart surgery at 38 provinces. Now the device is start coming in. I have the next problem. I don't have enough doctors. The cardiac, what do you call it, interventionist that can put the ring inside. And I said, I need around 50 doctors, and the capacity to produce every year is only 35 to 40. I have the money, but I don't have the center to produce. So I'm scrambling around because the cath lab are coming in with the World Bank loan. Then I'm knocking the door to Japan. I got 25 seats to do fellowship. I just learned about fellowship, or what this is a fellowship, to do cardiac interventionist. Go to China, got 100 seats every year. Go to India, get 20 seats every year. Now I have 150, 160 seats every year to do hands-on fellowship training for my doctors, and send them with my money to be trained. And again, so that is an exciting moment. I would like to close with something. It touched my heart even more. Indonesia produces babies a lot, 4.8 million, more than American. It is like the size of Singapore. So one Singapore every year. Out of these 4.8 million babies, one for every 100 have congenital heart disease, 48,000. 25% of this have a severe congenital heart disease, 12,000. That means they told me that if you don't operate this baby in 1 year, they will die. So I asked, how many babies you can operate? This professor looked around, 6,000. So what happened with the other 6,000? Because we have 12,000. They looked around and said, Mr. Minister, we afraid that is what we call natural selection. 6,000 Indonesian babies die because we don't have enough pediatric heart surgeon to operate on this baby because the heart is so small. So that is the reason why then I'm deploying 38 provinces the capability to do open heart surgery, including the pediatric heart disease. And this one, it's more difficult to train, what I learned. It's much more difficult than put the ring inside. So that is a short statement on the problem that I have in abscess. We solve it with the World Bank loan on the devices. Getting the people are more difficult.
Thank you, Minister. And Dr. Krishnamoorthy, I wonder if you can address that from the perspective of inequities, which the health minister also started to touch upon. And what are some of the challenges when we look at who is developing heart disease and who is able to access the treatments or the diagnostics that they need?
Yes, yes, and I mean, just an incredible story of how the minister, the political will, the acknowledgement, and the action that you're bringing. That's one of the most important parts to finding what is working, what's not working, and how do we deliver access to the people that need it the most. And I think, one of the things that we are finding is we can look at this as also upstream, more in the prevention side of things. And so, again, as we're talking about access, there is one thing, as the minister rightly found, that when you have an emergency and you now have to do the heart interventions and the surgeries, but there's also, and I think the minister as a banker will agree with me on this, if we can get to them in prevention. And right now we have over 70% of individuals that are unable to control their cholesterol levels. So then that is more and more leading to the cardiac arrests and the issues that they do have to deal with, and then having to find the hospitals, the surgeons, and that. And so I think it's one thing in trying to have really good screening programs, diagnostics programs, and then the right medicine, right time, right intervention for the individual, which will then have benefits to the society and to the communities, and also help with some of the healthcare workforce issues further down line. So I think, really important to be putting in place some of these more upstream programs and working with healthcare providers to be looking at some of these indicators that we might want to get after sooner than later.
Dr. Gaziano, I wonder if you could comment on the infrastructure required to be more prevention focused. Like we're hearing from the health minister that perhaps he doesn't have the luxury, right, of focusing on prevention because you have an immediate and acute need of people who have heart disease right now who need to be treated. So I wonder if you could just address that.
Sure, and I'm going to say these strategic plans we're talking about will need to address what we described, acute care, which is an important piece to this, the prevention, either primary or secondary prevention, meaning treating people with risk factors or early advance of disease, and even the public health sort of things of tobacco, controlling improvement of diet and physical activity are all parts of that. But on the area of particularly primary prevention, you're talking about the infrastructure that's necessary. That's why, again, we think that the plans need to be tailored to individual countries. I work in a very advanced practice in Boston, Massachusetts, where I can see a couple thousand patients over the course of the year. In East India, there's one cardiologist for the whole country. Where I work in South Africa, we're looking at, in KwaZulu-Natal, we're working in a region where there is no doctor at the clinics. Hypertension and cholesterol, if they're even managing it, is done by a nurse. And so what we need to do is tailor different implementation strategies, but all of them require access to the medicines that are available, or devices, or intervention tools. A health workforce, you've just described that very carefully. And it doesn't have to be, so some of the work is not going to be a pediatric cardiac thoracic surgeon. It may be a nurse is trained in managing lipids, or a lay health worker, which we're doing some implementation projects in Argentina and in South Africa, where we're having the community health worker, lay health workers, about 8th or 9th grade U.S. education, managing blood pressure and cholesterol under the guidance of a nurse or a pharmacist, and then ultimately a physician if there's a problem. So rethinking about the way care is delivered, and then the technology. So some of what needs to be the infrastructure is, we can bank, we can book an Airbnb, we can book our plane tickets, I can get on the train, I can do everything from my phone. We're not doing so much of the healthcare management of engaging patients in with their providers in a way that allows some of the care to be done in their homes, as rather than always coming into a brick and mortar site. So we've been looking at different technologies of measuring blood pressure in the homes, having that data transferred. And so but that means broadband infrastructure. It's not just healthcare, but I think it means access to those therapies that are affordable, to a trained staff that actually works as a team, to the top of their own ability, and not as necessarily having the cardiac thoracic surgeon measuring the lipids, but actually doing the surgeon during the surgery, and then maybe having a lay health worker that's helping manage these other logistics that are important. I've become more, I feel like, working for FedEx rather than a hospital. In terms of these logistics kinds of things, they're not a sponsor here or anything, but anyway, I'm just saying. But it is really getting down to the details of how do we deliver care to people, how do we let people engage and use the technology that we do have to do that. So I think these action plans are our roadmaps of what we talk about in terms of overcoming those barriers. What are the barriers in different countries to getting access to the training of the workforce, task shifting, and then what are the technological or financial needs of a country in order to be able to get people the care that they need where they can receive it.
Right. Minister Sadikin, when you look at that roadmap and look at some of the principles there in terms of addressing workforce and being a little more creative perhaps about using the community and people in the community to sort of do at least the primary screening or try to veer a little more toward the prevention side, as Dr. Krishnamoorthy was talking about. How realistic is that in your view?
Well, as a banker, I love preventions. The reason why, bankers love numbers. So I see all the numbers. United States, average life 79 years old. Average health per capita 11,000. Then I compare to Japan. The outcome is better. Average life is 84, better US. They spend average healthcare cost per capita is only 4,800. So I start questioning why the Japanese spend less money, bankers, typical banker, spend less money but get a better outcome. Right. And look for the best. Is there any country better than Japan? Yes, South Korea. South Korea spend, I think, 3,900. The average life is 83.9, close to Japan. The best is my neighbor, Singaporean. 84 average life, and they spend only like 3,300. So then automatically I check why Singapore is better than South Korea, West Korea better than Japan, why Japan better than United States? Because they focus on prevention. That's why as a banker I love preventions. So then I start learning about prevention after learning about this, whatever, pediatric interventionist, whatever it is, and I learn about Framingham risk score. So the cholesterol level, blood tensions, and also blood sugar. And also smoking. Indonesia love to smoke. So that's why everything is red in the Framingham risk score. So what we are doing now, with the World Bank loan, we equip and start already. I think it's already reached 8,000 our government primary care clinics out of 10,000. We have 280 million people, slightly less US. We have 17,000 islands, make it slightly more complicated. And we have 10,000 primary healthcare clinics to do prevention run by the government. So I deploy hematoanalyzer and blood chemical analyzer to measure three things, blood tensions, blood sugar, and blood lipid or cholesterol. If they told me if your blood tension is above 130/90, we give free amlodipine because it's already available at 10,000 per Christmas. If the blood sugar HbA1c is above 5.7, then we give metformin. It's our standard generic product. We have it. And if your cholesterol, especially the LDL, they told me not total cholesterol, LDL is above 100, then we give atorvastatin or simvastatin, all the statin family that give it to them to control. And now we started the screening 1.5 years ago after COVID. Now we screen already 60 million adults until July this year, out of 140 million target. 60 million. It's all digitalized. So that is the first screening. The second screening, what we are doing is slightly more advanced, is we are deploying what they call oximeter for babies, because we have a congenital heart disease. We distributing oximeter for babies at 10,000 per month already done to measure. They told me you can put one in the fingers, one in the toes, and then you can calculate whether the babies have a potential cardiovascular diseases. So that is already done. What we are implementing now is to distributing EKG to 10,000 per Christmas. Now it's only 6,800. To measure the EKG, if there is a potential heart disease, then we are deploying tenecteplase. Because some people want to use acteplase, but acteplase means you have to do injections, bolus, and also dripping. But tenecteplase, you just want to do one injection. So I said, choose a simple one. It's very expensive. Go to India and China to look for the cheaper product. Don't go to Merck. We go to the generic product in India. So we are going to India to get a tenecteplase to reduce the cost and do it. And the last one that we want to do, but actually not done, is because of stroke. We need a CT scan. We learned in China they put CT scan, they put Kusma. We cannot do it, it's so expensive. But now I look for there is a technology to put a 0.5 Tesla with artificial intelligence MRI. It's very small machines, don't need the lead, to cover the radiations, put in the Puskesmas, and then you can scan for ischemic or hemorrhagic potential stroke, and you can do the treatment in the Puskesmas. So I love prevention, it's cheaper.
Okay, so we've heard from the minister about things that he's prioritizing right now to address heart disease in his country. Dr. Krishnamoorthy, I wonder if in our last seconds you can just tell me if you could prioritize in an ideal world, what either issues or technology or programs would you wish were implemented more widely around the world to address heart disease?
Well, I think, the minister is just a leader and a shining example here. I think coming out of COVID, while we were going through COVID, we needed to shift resources, attention to COVID and infectious diseases. And I'm thrilled next year with the UN high-level meeting, we will be focusing on non-communicable diseases. And I think the first step is really building on this and acknowledging and recognizing all the unmet need that's out there on cardiovascular disease, and how with coronary heart disease, we really can make a difference. And so having more heart plans, cardiovascular plans that are roadmaps, that are funded and have political will behind them, we can really save lives around the country and around the world. And that is my hope for the coming year.
Okay, and really quick, Dr. Gaziano, I want to give
Have
you your...
nuclear physicists running most departments of health around the world.
I think we'd all support that.
No, so in addition to that, but that's the political will I think you're talking about. We will have the action plans that each country will address, but making sure that each of them has achievable targets and that there is a monitoring system in place to follow that. We've set the 30 by 30 goals or the 25 by 25 and then limited monitoring of those goals. So big goals with real targets, whether it's X number of people treated with high blood pressure, X number of people with the cholesterol level, and then the resources for people to get the workforce and the technologies and the pharmaceuticals to those people.
Okay, great. I want to thank all of you, and hopefully next year we can meet again and see how well we're doing on that action plan.
Thank you.
Thanks, everyone.
It's a pleasure.
That's a fact. That's easy.